Welcome to another episode of HMA's Vital Viewpoints on Healthcare, a podcast that brings together bold thinkers and seasoned practitioners to explore what it really takes to improve health systems, policies, and outcomes, especially for the people and communities who need it most. Today, we're joined by Sarah Hudson Scholle, a nationally recognized leader in health quality and person-centered care. With more than 30 years of experience shaping how we measure what matters in healthcare, Sarah has been at the forefront of designing quality frameworks that not only drive performance, but that prioritize people. Sarah has held key roles at the National Committee for Quality Assurance, where she led groundbreaking work on care for underserved populations. And she's also contributed to national efforts to improve care for populations with complex health needs. Now a principal at Leavitt Partners, an HMA company, Sarah supports cross-sector collaborations aimed at building smarter and fairer systems of care. Sarah, thank you for being with us today.
Thank you.
So I'm excited to talk about the word quality, the idea of quality. It seems like one of those words that people say, well, of course we should have quality, and yet I think often what people mean by quality varies. So I'm interested just to start. Over the time you've spent in academia at NCQA and now at Leavitt Partners, as you've worked across these different sectors, what are the through lines that you've seen over time and how we define and measure quality?
Oh, that's a great question, because as I was starting my career, that was the beginning of the efforts from the National Academy of Medicine to define the domains of quality. And what's interesting is that it is domains. It's not just one thing. It has to do with whether care is meeting the needs of individual people. It has to do whether it's effective. So is it going to achieve the outcomes that we expect to have? Is it care that is working for all different groups of people who might have different kinds of needs? So I think we've started to understand that quality is not one thing. It's not the same thing for me and for you, that we need to be attentive to what are the goals that individuals have in mind for their lives, and how does the healthcare system actually help people meet those goals and address the diverse needs that we each present.
As you mentioned, quality differs for each person and what they're trying to accomplish in their lives, what their health status is, and where they want to get to. How do we differentiate between the idea of quality and these quality measures, which is, kind of where we put the stake in the sand of whether somebody has achieved quality, right? Yes or no?
Yes. So I think people don't understand how until you get in the middle of it. When I started at the National Committee for Quality Assurance, I had no idea of how much work went into specifying all the details of a quality measure that will enable us to understand how does one organization compare to another. It has to do with defining the population, defining the amount of change you want to see, defining the code sets that you're going to use and what counts and what doesn't count. And what happens is that this entire sort of developing that quality measure involves a lot of research, involves understanding the data. But really, one of the most important pieces of it is inviting the different stakeholders who are part of that work to say, okay, will this work, and can we do something with it? Is from clinicians, can we actually improve it? So when we're trying to go from quality to a quality measure, we're trying to get at something that will give us consistent information across different organizations so that we can make fair comparisons. The challenge is that over time, these quality measures, which have been created to be part of how we hold organizations accountable for achieving the goals that we want them to achieve. We want to use that information to pay organizations for getting to better outcomes. But sometimes it's felt like oh, it's this measure that gets in the way and that forces doctors to document things in a specific way and forces patients all to achieve the same thing. And so it becomes a measurement exercise rather than a quality discovery and learning exercise. And so I think that's been one of the challenges that we've faced is it's more about the measurement and less about the quality that we're hoping to get. We want quality measurement to be fair. We want it to be comparable across different organizations. But we also need it to focus on things that really matter, not just the things that are easy to measure in a consistent way. It's like looking under the light post at what you can see to measure instead of saying, hey, what other information do we really need to know whether the healthcare system is performing as we hope?
That's a big question, whether the healthcare system is performing. How do you create measures that are meaningful for both physicians and for patients? If part of this is encouraging that quality discussion, as you talked about, their perspective on what is quality might differ. So how do you kind of square that circle?
I think that's been a real challenge for us in thinking about this process because, we've had some periods where it's like, okay, we need more measures. We need a measure for this condition, for that condition, for this health program. The thing is that it takes time to make a good measure. And it actually takes some practice. One of the things in my work that I've benefited from is having a couple of contracts from PCORI, the Patient-Centered Outcomes Research Institute. And, when PCORI came in, it said you've got to have patients and other stakeholders involved in every piece of the process of the contract. And so we were working on the use of patient-reported outcome measures in primary care settings, and particularly settings that were serving vulnerable populations. And what it required there? It required actually having a conversation among the clinicians and the patients together to say, okay, what's important here? How could we use that information? What's going to be the best way to collect it? How will we know what amount of improvement we should be able to see over time? And if you can't actually engage in that conversation in an honest way, then it's hard to get to a quality measure that everybody's going to feel like I can be responsible for this. And so I think it takes a lot of time to have this conversation, actually takes a lot of practice. And learning from organizations that are really committed to this kind of work is important because it's those examples that can help us learn what is possible and what might be achievable.
And I have to ask this question. I have very much had a love-hate relationship with statistics in graduate school. So I ask this with that lens. How much of it is looking into data to figure out what might be predictive? Starting with a set of here are things we think might be predictive, and then now, how do you feel about those versus kind of a top-down, here's what we think matters to us, and then let's kind of create a variable or a data capture moment in order to measure that. How much of it's kind of coming from which direction?
Well, it's both. It's actually got to be both. But what we're trying to do is we're trying to change behavior. When we create a new quality measure, we're doing it because we want something to change. We want care to improve, right? So when we create a quality measure that is about improving outcomes for people with depression, we're saying we're not doing a very good job now. We want something to improve. So that means people have to change. And it's actually on both sides of the equation, right? It's the care team, the clinician, the organization might have to change what they do, but it's actually requiring a commitment from the patient as well. We need your information to help us do a better job and help you to get better. What does getting better look like for you? How can we help you? We can look at research that says, okay, well, about a 50% improvement in symptoms is a response, and we're going to use that as a number. We did that, and actually getting rid of depression symptoms, that's remission. And so that's what the clinical trials were developed around those ideas, remission and response. Well, guess what? We created that measure. We made it available. It became it's a HEDIS measures now, but it's actually not reported by very many plans. And part of the reason, I mean, there are many reasons. One reason is it's just hard to collect the data, but another reason is we built the definition of remission and response based on research data, based on what we knew from the literature about what would be a good improvement in a clinical trial. What we didn't do was sit down with patients and clinicians and say, okay, let's think about what would it mean to see improvement? What does getting better mean to you as a patient? What are the tools you need to have in your toolbox to help this patient get better? And so that's the kind of collaboration in the learn and improvement process that actually hasn't had enough influence on how we develop measures and how we develop learning health systems that are really going to work to improve, rather than spending all their time trying to figure out how am I going to get the data and then and how am I going to report it, rather than saying, okay, what will it take? And in particular, I think people are afraid that when you ask patients, they're going to ask for the moon. In fact, as I've worked with patient partners and different projects over the years, they're actually so practical and so reasonable. I mean, the first one, I remember patients saying, well, what are you going to do with these data? I mean, I don't fill out these questionnaires because I don't think anybody reads them. That is the kind of honesty and truthfulness that you want to have at the table, so that you say, okay, well, then how do we explain that? What are we going to do? What do we need from you as a patient in order for us to be able to serve you well? A lot of the work that we did at NCQA, I was excited to be part of the development of a set of measures called person-centered outcomes. And that really rests around this idea of saying, okay, when we have people who have complex needs, that might be older people that have multiple medical conditions, that might be experiencing life-threatening or life-limiting conditions, or when we have people that have physical or mental health disabilities and that might be competing with medical needs, with non-medical needs. Like in that case, some of the standard quality measures we've developed just don't apply. And so we don't have a way to say, is your care as good as it should be? And so that's why we developed a set of measures. But it really starts from a conversation of trust about, well, what are your goals? What matters to you? What would a good day look like for you? And I remember interviewing patients who said, nobody's ever asked me what my goals are. I don't know how to answer that question. We had to actually create a script about how to have that conversation because it was so foreign to patients, but also for clinicians. So there's a lot of training that has to happen, but it's that partnership that is actually what's going to help people improve. And it's through that partnership and that relationship that you can begin to build on some of the challenging behavior changes, the challenging other kinds of non-medical situations, making the decisions about whether a particular healthcare intervention is actually going to help. And that's a kind of frank conversation we want to see. That requires time. And that's another challenge with this entire quality space, where we have clinicians saying the whole visit is based on trying to fill in all these different quality measures. I actually think there's a tremendous amount of progress being made to make that more efficient. I'm excited about movements in interoperability that I think will help to make that data sharing and the use of new tools to make those data available for understanding people's needs and quality of care. I think that's happening. It has to happen in order for people to feel like they've got the time to actually have that relationship.
I want to come back to the topic of kind of digital quality measurement, which I know you started to go there, but before we go there, I just in my previous career doing sort of healthcare market research, oftentimes, the patient's experience of what quality or what value or whatever word we might want to use really starts with convenience and affordability. And so I just wonder how much those factors, being able to have somebody answer the phone when I call, or, getting an appointment in a reasonable amount of time, like those things that are very far outside, well, sometimes outside the realm of what clinicians can influence. But for my patient, what do I need to be healthy, to stay healthy, to be, some of it is the system needs to work for me. So how have those kind of concepts evolved, and do you see any of those components being pulled into these kind of definitions of quality if we're going to get to a better patient outcome and achieve those behavior changes that you're talking about?
We do measure some of those aspects of care access, and they're really important, right? Because if you can't get that phone call, then you might end up at the emergency room because you don't know what to do, right? So it is important to create frictionless care. So both from the perspective of the clinician and the care team, but also the patient, because you want patients to feel like you're you're important. Your needs are being met. But for some people, it's way more important than it is for others. I think, when I look at the way that we've asked people about their experiences of care, we've done some good work in trying to understand things that are just kind of timeless about can I get information when I need it? Do people respect me as a person? But there are other things that we don't ask about, and that's about, do I trust my provider? Do I feel like I'm going to get good advice? This is someone who knows me. And people will attach different kinds of value to those different pieces. Right now, we have pretty much a static kind of approach instead of one that can help you as a person say, look, this is what's important to me. And how do I find the right kind of care setting, the right clinician that's going to support me? It's important to think about that customer service piece of making this an easy way to get care. At the same time, we're trying to help people, get the right kinds of care. I think given sort of the constraints on resources and time, it can be challenging. I think that's why you see different groups of people gravitating to different kinds of healthcare systems. I know my values and what I value for care is different from my colleagues. And some of it has to do with, well, I don't have a major illness. I'm what I care about is that I know where I can go and all of my records in one place. And other people, it's like, I want a relationship with the doctor I choose. And I think really being able to customize and personalize how we think about care, I think that's kind of the next frontier in quality. Like, how could that happen?
Some of that's clearly personality, or just, what's important to you in your life, but it's also like, what are you managing within the healthcare system, right? Are you managing prevention? Are you managing, kids' physicals and paperwork and things that have a higher premium on convenience, or are you managing an onset of a cancer diagnosis or something where you're like entering the system in a meaningful way and need to coordinate? I mean, both of those can have similar a backbone of, having data sharing. And let's talk more about kind of the digital opportunity. I mean, in both of those scenarios, better data sharing would improve that experience, right? Avoiding the repetition, avoiding the confusion, avoiding the misinformation or unnecessary charges for things that already were done in another setting. Even though what those two people might value might be different, but there is an opportunity to kind of improve the system for both. So talk a little bit about how kind of digital this, the interoperability, and I know there's lots going on this week about it in particular, but how these kind of digital frameworks, I guess, are going to move the needle on some of these quality measures.
Yeah, so the announcements from CMS about the new interoperability framework and its commitment to making available the ability to have access to their data and to be able to share their data with other providers. This is great. It can definitely reduce some of the redundancy. Definitely hear a lot of complaints about, oh, I got this and I have to fill this out again. I already did it. There's an incredible opportunity for people to contribute to that data stream. This is where there's an opportunity for the patient to say, here's what I want you to know about me. I do work with Special Olympics about healthcare needs for people with intellectual and developmental disabilities. And in that environment, we heard from patients and family members how important it is to be able to say, here's who I am. Here's how I like to communicate. Here's what's important to me in my life. You should know this about me. And, so excited that in some health systems, they actually have something like a header on their record that allows the clinicians who are meeting them to see that. How tremendous if that's something that you could have in your health data app, that you could say, here's the header. I want you to know this about me. And that's the kind of value of the information that's coming from the patient or from the family or caregivers when the patient needs help. It says, here's what you should know about me. Here's what my goals are. Here's how I like to spend my time. Here's what I'm trying to get to. Here's how I like to be addressed. Here's who I am. Now, let's work together. That kind of information, be able to make that available, I think that will help people. It's, I'm less excited about CMS sharing data with me than I am about being able to say, here's what I want you to know. And I think that's an opportunity with this data exchange that can happen. I also think it should be able to lessen a lot of the drudgery in the quality measurement process. If something happened here, you get credit for it instead of having multiple people have to ask the same questions about smoking or about, did you have this mammogram, right? So that information is available to all. And, but also giving opportunities to say, okay, I see this hasn't happened, and can we help you? Do you have any barriers? Do you need more information? In my world, in my ideal, this move to interoperability actually sets up an opportunity for multi-way communication, particularly for people that are managing with multiple doctors. I help to manage some of the healthcare events for my 93-year-old father, and I've got a bunch of logins for him, and it's a nightmare. But more importantly, I want those different providers to be aware of what's going on at the other place. And if this can help to make that smoother so that there's less repetition, but also less opportunity for an oversight, it should certainly, I hope, help members of the care team, the clinicians, to spend less time on documentation.
How do you kind of think about patient privacy issues? I've seen in some of the reporting this week, some of those issues pop up. And in some ways, it's two sides of the same coin, right? You want it's convenient and it's perhaps more effective for your clinician to know more about you and what's important to you. But at the same time, there's, kind of the slippery slope. And especially when you get to issues like mental health or substance abuse that have been so deliberately kept in separate silos from the physical healthcare system for so long, and yet are so critical to providing whole person care. So how are we threading that needle with what is rightfully very exciting about interoperable data, but also like who gets to decide what goes in and out? How are we threading that needle?
This is such an important question. In fact, I was talking with with my colleagues who are, on the leading edge of all this interoperability work. And I said, when you feel like your needs have not been understood, or when you feel that information about you has been used against you rather than for you, then you approach this opportunity with a lot more skepticism about, well, who's going to have the data? Who's in control? How do I make sure that I can share what I want to share and not share what I want to keep private? And how do I trust that the consumer-based apps that will be kind of the place where these data get shared, where these transactions happen? How do I trust them? Now, fortunately, the Karen Alliance has a website, the myhealthapplication.com website, of application vendors that have signed on to a code of conduct about data sharing. And I think that's really important. The regulations about data sharing and apps and what they can and can't do, that falls actually to the Federal Trade Commission. I really do think that this question needs to be addressed clearly, and we need to figure out what are the concerns that people have. Do we need additional privacy or security settings that will allow people to feel comfortable in sharing data, particularly data that they feel could be used in unexpected ways or unanticipated ways? It's a huge issue that we need to deal with. I think we have some structures in the private sector and in regulation that can help to address that. But I think it's a big point of training and education. And it may be that we need to make some additional efforts to really make sure that those concerns about privacy and security are actually being carefully addressed. We all know about data mishaps that have happened. And so, many people go into this not feeling like, oh, this is great, all my data goes somewhere else. It's that we need to be able to prevent those kinds of actions. And that's going to require that the companies that are in this business are really thoughtful about it, that clinicians and patients really understand what they're getting into, and that organizations are vigilant.
Yeah. I was going to say, it's like we have, you have data breaches everywhere, and yet you're giving more and more of your information into your phone every day. And yet it's almost like you're numb to it, because like every health system where you get a note, it's like feels like once a month you get a note from somebody that's had a data breach. So we're sort of simultaneously more skeptical and also sharing more. So it's, there has to, so the framework is important, and the entities that you mentioned, understanding what really needs to happen to make it work, I think is really important here. Does this all lead us then to more measures, or just more inputs to fewer measures? And I know that there's been rhetoric in the past of, we're going to cut, there's going to be fewer measures. And I remember a former mentor of mine, Dr. Mark Smith, saying, like, it's not really about more or fewer. It's, are they the right ones, right? Because it might be the right ones are actually more, and it might be that they're less. It kind of depends on the issue and the illness and the outcome. And so having more pieces of data now through this kind of digital infrastructure, does that help us simplify, or does that inherently make it more complicated?
I do think Mark is right? So it's having the right measures. And it's also kind of figure out what's the balance, right? Because when you have a quality measure that is used in a high stakes purpose, like paying health plans their bonuses in the Medicare Advantage program, or paying for doctors, those are high stakes purposes. And there, you really want to be confident that the data that are being used, the quality measures and the data that are reported are making fair comparisons. And that takes a level of scrutiny and data collection and expense that is not always needed when the purpose is for quality improvement. And I think part of what because in quality improvement, we're trying to look at the data. We want to look at it over time. It might be changing. What do we learn over time? It'll be okay if the data come in different formats or at different points in time. It doesn't all have to be exactly the same data collection process everywhere. It's not a research study, right? So I think part of what is going to be important is for us to figure out, like, what are those high value measures that we are comfortable using in these accountability arrangements? And are those measures that capture things that are important to people, capture things where clinicians say, I can be part of this. I know what to do. I believe that this is valuable for my patients and for my organizations, right? So we want those measures. And if you look at the Universal Foundation of Measures that CMS leaders posited a couple of years ago, and they've been making progress in moving to that Universal Foundation. So it's a small number of measures in key topic areas. That is progress. There also needs to be an opportunity for building new measures that are going to get at new things that people care about. And that is from a learning process. And that's where we are, in particular, with measures that are based on patient-reported outcomes that are about what matters to people. We need to have experience with those measures in the real world. We need organizations to be building those. And it's likely going to be different because different patient groups with different kinds of conditions might need a different way to measure functional status. Like, functional status is like, okay, can you do the things that you want to do? Well, that's going to be a different set of questions for people with back pain than for people with congestive heart failure, than people with a disability. And actually having the flexibility to think about that, I think we actually haven't had the data to be able to say, hey, let's figure out a way to look at this information that's coming in from different tools and try to create some cut points or boundaries that are consistent. We can do that with different tools for depression. We can say 5 different symptom scales for depression. We can say what's an equivalent cutoff across those scales. I think we need to be thinking about, well, how do we do that? And in a world where we have access to more detailed patient level data, more data that's collected over time in the course of care, I think we're going to actually have more opportunities to be using creative approaches like that. I believe the focus should be on, are you helping people get better? That should be the first focus. We probably need to limit some of the requirement for other kinds of measures if we want this kind of innovation to happen. We actually have to make space, both in terms of how organizations focus their quality improvement efforts and how clinicians think about their time. I think actually engaging patients and saying, okay, how do we do this together so that it doesn't become a challenge? Like, organizations that are using patient-reported measures, like in the hospital program where there's hip and knee replacement outcome measures, they have a really hard time getting patients to respond to questionnaires after surgery. How do we make that clear that we need to know how this is working for you, because that's what we need to do to help the next patient? And I don't think the quality world has really tried to engage patients in that conversation. It's your information that's going to help us determine whether this is high quality care. And if you want that for yourself, we need you to help give information, because that's going to help us with your community that you live in, with other patients like you. I think there's a great opportunity here, in particular, when we do encounter problems. I've been talking with some folks about patient safety issues and how we miss so many opportunities to identify patient safety events, right? Where there have been medication errors because they don't get reported. Who is most able to see when there might be a disconnect? When, oh, that medication is not the right one. Here, wait, here's the list. It's the patients and the families that are there. So I think there's also an opportunity for people to say, to bring their experiences, good and bad, but it needs to be in a way that there's a commitment and a relationship and an understanding. It's not a gotcha. It is about, hey, we're all working to improve this healthcare system as patients, as families, as clinicians, care teams, as organizations. We have to do it together.
You may have already answered this in some form, but I want to ask you our kind of standard question here, which is, if you had a magic wand and you were able to wield it to kind of make all of these things work better, more seamlessly, the kind of new world order that you've described, how would you wield that wand?
Well, the first step has to be we've got to listen to patients and families. So how do we do that? And what are the different ways that we can involve patients and families in the policy world across the board? And it needs to be not just people that are going to raise their hand. It's going to have to be, okay, let's go find people that might be disengaged from this system. We need those voices involved from the policy level. We need that involvement in healthcare systems. And, many hospital systems have patient and family advisory council. This is a great way to do it. But it's not just kind of advising, it's actually participating in the quality improvement. It's actually talking to people and following them on their journey through the healthcare system. So that part of saying, so what's important to you at this point? What happened? How did it happen? And that's, we have dozens of stories of healthcare organizations that do those things and use that to guide their improvement efforts. And yet I don't think we use that resource that's available to us as much as we could.
Yeah, that makes sense. Well, I thank you very much for your time today. Hopefully, others have found this as illuminating as I have. It's one of those, as I said at the outset, you think you understand what quality means, and yet it's so much more complicated than that. So I appreciate you laying it out for us today and helping us understand where this movement's headed. So much appreciated.
Thanks very much. I enjoyed it.
This episode of Vital Viewpoints on Healthcare is sponsored by HMA Information Services. HMAIS is a subscription-based service that provides state-level data on publicly sponsored programs like Medicaid. From the latest managed care enrollment, market share, and financial performance data to up-to-date RFP calendars and state-by-state overviews, HMAIS has all the information you'll need to power your initiatives to success. This podcast was produced by myself, Jennifer Colomonico, along with Tiffany McKenzie, in collaboration with our guests. The content is the property of Health Management Associates.